Yeah, I think there's two challenges that I could identify in treating the older and frail population. One is, what do we do with the high-risk patients? And not high risk from a biologic perspective in myeloma. Now, there's less frequent high-risk abnormalities in older patients, but and we really don't know what the right treatment is. Should we be getting Dara-RD? Should they be getting a bortezomib-RD? Or maybe is this a patient population where they can get a dose-modified quadruplet? We really don't know that answer. And the other major challenge with these patients is the toxicities of the regimen. So it's very important to focus on, to balance the efficacy of these regimens with the toxicity. I think the easiest thing to do is to minimize the dose of dexamethasone. Patients over 75, we always start with 20 milligrams of dexamethasone. There's now regimens that are dexamethasone free. And for patients who need a rapid response because of disease burden, having dexamethasone in early makes sense. And then having rapid discontinuation of dexamethasone also makes sense. And that's supported by randomized clinical trial data. The Italian group did in the non-transplant candidates, did a randomized study of Len-Dex, and then after 9 months, the patients were randomized to ongoing Len-Dex like they did in the first study, or the maintenance lenalidomide at lower doses with no dexamethasone at all. And the outcomes were the same between the two groups. So we know that after 9 months, dexamethasone is not needed anymore, and it's likely much earlier than that.